IQ community, and welcome to our presentation, Mental Health Across the Lifespan, a focus on late life depression. I am Beth DiNapoli, a medical science liaison for Otsuka Pharmaceutical Development and Commercialization, and I'll be serving as the moderator, and Dr. Alexopoulos will be our topic expert for today's exciting discussion. So let's start by introducing our esteemed speaker, Dr. Alexopoulos. He has published more than 350 articles and book chapters on the psychobiology of geriatric mood disorders and on effectiveness in services research. He founded the Weill Cornell Institute of Geriatric Psychiatry in 1994 and still serves as its director. Dr. Alexopoulos is also the director of the NIMH-supported Advanced Center for Interventions and Services Research in Late Life Depression. He is the S.P. Tobin and A.M. Cooper Professor at Weill Cornell Medicine, Professor of the Graduate School of Medical Sciences, and Vice Chairman of Geriatric Psychiatry. He has served on the board of scientific counselors of the National Institute of Mental Health and several other organizations. And lastly, Dr. Alexopoulos has been the editor for Western Hemisphere and Japan of the International Journal of Geriatric Psychiatry for over 20 years and is on editorial boards of several other professional journals. Thank you so much for joining me today, Dr. Alexopoulos.
Thank you, Dr. DiNapoli.
Now, before we begin, just as a disclosure, I wanted to remind the listeners that this presentation is sponsored by Otsuka Pharmaceutical Development and Commercialization and Lundbeck LLC, committed supporters of mental health treatment community. I am an employee of Otsuka, and our speaker is a paid consultant to OPDC. Now let's begin with the problem. I think it's a well-known fact the world's population is rapidly aging. You can see some of the statistics there on the slide. Between 2015 and 2050, the proportion of the world's older adults is estimated to almost double, from about 12% to 22%, and that's an expected increase from 900 million to 2 billion people over the age of 60. And older adults face special physical and mental health challenges, which need to be recognized. In fact, over 20% of adults age 60 and over suffer from a mental or neurological disorder. And we've listed out some of the most common mental and neurological disorders there on the slide, and that being anxiety, dementia, and depression, which affect approximately 4%, 5%, and 7% of the world's older adult population, respectively. Now, Dr. Alexopoulos, I wanted to hear from you. You've been in the older adult mental health domain for a long time, and I'd love to hear about your clinical practice and what mental health conditions you commonly see in older adults.
Thank you. I direct the Weill Cornell Institute of Geriatric Psychiatry, which encompasses all the clinical services of geriatric psychiatry of the medical center, and also is the research institute for the medical center. Now, we have a very active inpatient service, an outpatient clinic, and we offer services to nursing homes. Our patients are variable, but the vast majority of them have some mood syndrome. Principally, depression is the most consistent diagnosis that we see. Our research center focuses exclusively on late life depression. So we have from the research center, we have a lot of research patients with a variety of depressive disorders of late life.
That's very helpful for us to know. And just speaking to that, we're going to focus the rest of our conversation on late life depression because, as you just noted, it's one of the most frequent causes of emotional suffering for later life, and it significantly decreases the quality of life in older adults. So on the next slide, we have some of the presence of major depressive disorders in older adults. And you can see that it varies based on the acuity of the setting. So from 1 to 3% in community residents, going up to about 10 to 15% in primary care and acute care nursing homes. And I think the most alarming statistic is that at the very bottom, that last point, that in nursing homes, major depressive disorder is a risk factor for mortality over a 1-year period and increased the likelihood of death by 59%. So because of this, depression, it's prevalent, it's a treatable condition, and it's also associated with this increased risk of mortality. Recognizing it and treating it is imperative. So I'd like to now ask you, Dr. Alexopoulos, we have that on the left-hand side of the slide. Even though the core symptoms of major depressive disorder are the same, regardless of age, could you speak to how depression may present differently in older adults?
There are a variety of presentations. Apathetic depression is a common presentation, especially in medical populations. So if you in primary care patients, but particularly in nursing home populations, you would see a lot of apathy. And in fact, people may not use the word sadness or depression if you speak with them. They simply become listless, lack energy, and essentially withdraw. All their behaviors are reduced. And then they may have the rest of the syndrome, such as melancholic symptoms or anxiety symptoms. In the community, if you see people coming from their home, depending on the severity of depression, let's say if you have a high severity of depression, you're quite likely to see melancholic symptoms, meaning middle insomnia, early morning awakening, most prominent symptoms in the morning, prominent symptoms of guilt, at much higher frequency than you would see in a young population. Also, in a young population, for example, in people in their 20s, it is rare to see a full melancholia syndrome. If anything, you might see an atypical presentation with weight gain and listlessness and fatigue, but you wouldn't see a full-blown melancholic syndrome. Other symptoms of late life depression is cognitive impairment. Now, think of cognitive impairment as something happening that is an underlying reduction of cognitive reserve, if you wish. And when the depression hits, the person runs out of cognitive power and they express cognitive symptoms. I think these are the main differences. Other differences are in the course of illness, that late life depression is more difficult to treat, and we'll speak about that later when we speak about treatment. It's more difficult to bring to remission and has a shorter time to relapse. About 50% of patients with late life depression, even if they achieve remission and stay on meds, they will relapse within a period of 2 years.
Yeah, thank you, Dr. Alexopoulos. I think those are important points to make in terms of letting clinicians know that depression may present differently in older adults and they have a different course in terms of the illness. On the next slide, I think another really important point to make is that oftentimes older adults may also be experiencing chronic health conditions. So depression has an impact on physical health and vice versa. I know this slide is a little complicated, so I'm going to turn it over to the expert to explain this relationship further and walk us through the slide.
You noticed in the previous slide that nursing home populations, which to translate it in medical terms, nursing home populations are people with many medical illnesses and disabilities. They have 15% prevalence of late life major depression. What does that mean? It means that medical illnesses breed depression. So looking at the right side of the slide, you would see that a number of medical conditions such as cerebrovascular disease, TIA, stroke, coronary artery disease, and diseases of the basal ganglia like Parkinson's, progressive supranuclear palsy, and Huntington's disease, they all predispose to depression. So a patient who, as an example, a patient who has a stroke in the left basal ganglia has about 75% chance to develop depression. So also patients with dementing disorders, in particular vascular dementia, as well as Alzheimer's disease, but most prominently vascular dementia or mixed dementia, meaning vascular dementia plus Alzheimer's disease, have a very high percentage of them develop depression, more than 20, 25%, according to some, even 50%. I tend to favor the lower percentage, the 20 to 25%. Cancer patients, pancreatic cancer and lymphoma are well known for many years that they cause depression. It's the exception of patient who doesn't develop it, but they are not the only cancers that cause depression. Finally, autoimmune diseases and endocrine diseases cause depression. So this is going from medical illness to depression. So the medical illness predisposes to depression. But depression itself has adverse consequences on medical health. First, we now have strong evidence that depression promotes advanced aging. So it ages the brain. People with depression have a faster aging brain than people without depression. And that has been shown in a variety of ways. Now you can measure brain aging through imaging techniques, and you can measure aging through telomere length. Second, depression itself is accompanied by pro-inflammatory changes in the brain and in the periphery. So chronic inflammatory states essentially undermine general medical health and brain health. Depression clearly predisposes to obesity, to frailty, and to disability, and those conditions themselves compromise medical health. Depression deregulates diabetes. It promotes coronary artery disease and cerebrovascular disease. It increases the likelihood that one would develop cancer and one would develop Alzheimer's disease. So the point here is that there is a reciprocal association. Depending on the chronology of what happens first, the arrow goes in one direction, but then it comes back again. So let me just mention what I mean by this. If you have coronary artery disease, you might develop depression. If you develop depression will worsen the outcome of coronary artery disease. This interaction causes a vicious circle to start, and hopefully it can be interrupted with treatment many times, but never always.
I think those are great points, Dr. Alexopoulos, particularly in highlighting the need to assess for depression in those individuals with chronic health conditions, but highlighting the reciprocal relationship between them.
And I would emphasize that not only you need to look for depression in people with chronic medical conditions, but you have to look for medical conditions in people with depression during the episode and after the episode. Now, what my colleagues at the Research Institute, at the Weill Cornell Research Institute did, is that we try to take advantage of that relationship and develop a working model of depression. And you can see that here, the model that we and a number of others have been working on. And starting from the top, vascular changes, inflammatory responses, amyloid deposits, and genetic factors act as causative factors for depression. So they, either directly or in response, in interaction with biological expressions of stress, they may cause, and you can see the responses to stress on the right part of the slide, they may cause impairment, dysfunction of the reward network and the cognitive control network. And when that happens, then you see symptoms of depression, usually as the clinical expression of the dysfunction of the reward network, or executive dysfunction as a clinical expression of a cognitive control network problems. Now, I wanted to emphasize that when we think of stress, we often think of psychological stress. But when somebody is stressed, a number of biological events take place. That is, the increase in inflammatory responses, decrease in neurogenesis, increased oxygen-free species, free radicals, and the altered brain connectivity at rest. Now, there is another pathway. People would ask me sometimes, they say, okay, do all people with vascular events develop depression? The answer is no. Some of them will develop depression because they hit at the right centers, and they will develop what you see at the bottom, depression executive dysfunction syndrome. Others are hit in other centers in the brain and then they develop brain abnormalities that serve as predisposing factors. And those, again, alone or in interaction with stress, they may lead to the development of depression. So as you can see, this model encompasses the bidirectional interaction between medical and neurological illnesses and depression itself, and explicates why we see disturbances in reward and cognitive networks, and as a consequence, we see depression and executive dysfunction syndromes happening in late life. So based on that model, we proposed three hypotheses. The first is the executive dysfunction syndrome hypothesis. This is we call it DED, depression executive dysfunction syndrome of late life. The significance of that syndrome is that it doesn't respond well to treatment, to pharmacotherapy. And as a consequence, we have been developing a number of behavioral approaches to attack the disabilities of that syndrome and prompt the reward system to work properly. The second is vascular depression. That is a depression that is predominantly caused by vascular disturbances in the brain. There, we don't have good treatments to treat vascular depression itself, but we have good preventive treatments. That is stringent control of hypertension and also anticoagulation therapies, as well as therapies for reduction of hypercholesterolemia. The inflammation theory is based on the causal factors that you can see on the right-hand side. The inflammation theory has been developing for years for a number of depressive syndromes. We have applied it to late life as well. At this point, anti-inflammatory agents have mixed results, and they seem to work. If I may cite a study has shown that if you have elevated CRP, C-reactive protein, it is more likely to respond to a tricyclic antidepressant than to an SSRI. Conversely, if you have low CRP, meaning low index of inflammation, there is no difference between the two agents, and perhaps even is better to be treated with an SSRI. This is the current thinking and the model that we have been working on, and I want to say that this model is broad enough and has been used by other colleagues who work at various aspects of the model.
Thank you, Dr. Alexopoulos. I think that's really helpful in our thinking, but also points to the complexity of late life depression. And I should have mentioned this at the beginning when I was presenting the most common mental health conditions in older adults, but I think it should also be noted that a lot of times there's symptom overlap and there can be a co-occurrence of these disorders. So symptoms of anxiety are often present in major depressive disorder, and similarly, as Dr. Alexopoulos already talked about, cognitive impairment is often present in late life depression. And depression and dementia have very similar symptoms. So I'd love to hear from you, Dr. Alexopoulos, because I can't even imagine how you disentangle all this and figure out what's going on. So, whether an individual has major depressive disorder that's impacting cognition, or maybe a depressive pseudo-dementia or dementia with depressive symptoms. Can you elaborate on how you approach this?
Sure. Well, the answer is with great difficulty. First, let's start, before we talk about disentangling them, that late life depression by definition happens in old people. Now, what happens to the brain when people age? There's loss of cortical volume, especially in the frontal cortex and in the hippocampus. And these are areas critical for planning and for memory. Making a plan and following and sequencing your behavior and following that plan, and also for memory. The second thing that happens is that there is reduction in cortical thickness. And why does this reduction happen? It happens because people in late life, as they age, they lose synaptic connections, and therefore the connectivity among the various centers of the brain gets weakened. The last point is that people lose white matter. They lose white matter preferentially. By the way, we do not lose brain cells in late life. People believe that we lose brain cells. That's the least of our problems. We lose synapses, we lose volume, and we also lose white matter predominantly. And white matter is the connective tissue of the brain, it's the wiring of the brain. So the brain overall, because of this change, is compromised. As a consequence, when depression occurs, what you see is it unmasks, it uncovers the vulnerability of the brain. So what we see, what happens if you have white matter loss? White matter connects the various centers of the brain. Your processing is slowed down. So it's very interesting that I write a lot, and I think over time I have gotten better in writing. But when you write, you don't need speed. What you need is clarity, which is okay. If you don't lose brain cells, you can process, but you process slowly. But when I try to learn a new computer program, I'm slow. And the computer programs are created, they are created for younger people. So you can see the difference. So old people, when they would get depression, they would have inattention and they would have slow processing. So it may go further than that. Now, if you see more than that, if you see executive function, some of them may develop eventually dementia. Most do not. Most will have what I called earlier the depression executive dysfunction syndrome, that many of them do not become demented. They stay in this particular state. Then you have people who, by definition, to call something dementia, you have to have memory impairment. You have memory impairment plus one other function. So now, if you see somebody with severe depression and cognitive impairment, and you take history, and by history, that person was not demented until he developed a major severe depression. And that person, the depression subsides and he gets better. That used to be called pseudo-dementia until 1993, when my group wrote a paper showing that if you follow these people long enough, about half of them will become demented. So pseudo-dementia is not quite pseudo. It is dementia unmasked by depression in the majority of cases. So to go back then to what you asked me, how do you separate all this? So you separate, if you see just slow processing in the context of depression, or if you see just inattention, I would say this is probably just a depressive syndrome. Don't worry too much about dementia. If you see mild executive dysfunction, like difficulty with planning, difficulty with organization, difficulty with sequencing your behavior, disproportionate disability, behavioral disability as a consequence, I would think that this is a depression executive dysfunction syndrome of late life. But if you see planning, visual planning problems, for example, a person who cannot connect 1A, 2B, and so on, this is a trail speed test. Or if he cannot draw a clock right, or if he cannot draw a cube right, then you're speaking about a severe executive dysfunction. That is probably related, is something that may be dementia, maybe a vascular dementia, or some deep subcortical structures abnormality that would express later as a dementia. The point that I wanted to make is that if somebody meets criteria for what used to be called a pseudo-dementia, which means dementia in the context of major depression, and he recovers, I would follow this patient because in all likelihood will develop dementia.
Yeah, it sounds like neuropsychiatric assessment is important a lot of times in this population. And then to your last point, you probably would want to follow up with these patients to see how depression's progressing, their cognition, etc. And that's going to help with disentangling what's going on. So we started with the problem. I want to conclude with what can be done. Dr. Alexopoulos already kind of talked about this, but depression in older adults often follows a chronic course, and incomplete remission of MDD may lead to relapse. So I'd like to ask you, Dr. Alexopoulos, what evidence-based treatments are there for late life depression, and are there important things to consider when treating this population?
Right. Antidepressants work, but they work less well in late life depression than they work in early life depression. If you think of number needed to treat compared to placebo, with antidepressants, you need 14.5 patients with antidepressants in order to identify one remission over placebo. Okay, so the number needed to treat is 14.5 for remission. The number needed to treat in order to achieve response is 6.5. So response is defined as 50% reduction of depressive symptoms. But as you pointed out a minute ago, if you treat incompletely, again, response may mean incomplete treatment, since only 50% of symptoms drop. You have a better outcome with antidepressants, but not great outcome. The recurrence rate, as I mentioned earlier, once you achieve remission, and even if you stay on medication that got you well, you have 50% chance over a period of 2 years. In fact, with severe depressive syndromes, many people relapse. Now, ECT is the most effective treatment we have. It is justified in severe depression or in suicidal depression or in depression that is progressive too rapidly. It is a great acute treatment. So the probability of response with ECT is very high, is approximately 60 to 80 to 90%, depending on the type of depression. The problem with ECT is that if you stop it, you have a high relapse rate, especially if the reason that you administer ECT is failure of depression to respond to antidepressant drugs. So there we have there are a number of studies in which show that maintenance ECT works, but even maintenance ECT together with pharmacotherapy still has a significant relapse rate. Psychotherapy has been underutilized, although there are many studies showing that it is effective. My colleague Pat Arian and I have shown that problem-solving therapy is quite an effective treatment. CBT has been found by others to be an effective treatment. And most recently, we published in Molecular Psychiatry in 2020, we published a paper showing that a treatment that we call Engage is easy to learn and maintain skills, and has comparable efficacy to problem-solving therapy, PST. We hope that creating a number of similar to learn and maintain skill psychotherapies would be an important addition to pharmacotherapy and ECT. We started having a handful of cases treated with ketamine, and we predominantly treat patients with ketamine who either do not accept ECT or do not qualify for ECT because of medical contraindications. And they have done quite well, a good number of them. So the final point, of course, based on what we discussed, is that we should be thinking of preventing causal factors of depression by treating hypertension, obesity, hypercholesterolemia, and so on. And we should be trying to start doing that in early life.
Thank you so much, Dr. Alexopoulos. I think you provided such an informative commentary. I'm sure the audience found it valuable. I know it's a passion for both of us to treat late life depression, so hopefully the listeners found this very useful and can translate it into their clinical practice. I hope you enjoyed the presentation, and please be sure to check out the other resources we have on mental health care across the lifespan.
Thank you.